Okay, well, welcome everyone to Paediatric Teaching today. Today I wanted to talk about oncology, and people who are paediatric oncologists will be able to tell you a lot more about the details of cancer in children, but I wanted to give a generalist perspective of oncology. I look after a lot of children who have um, cancer, and so from the point of view of paediatric trainees at a diploma or master's level, I'm going to try to explain to you the essential things you need to know to manage children who have oncological problems. So today we're only going to talk about 6 different topics. One is about acute leukemia, other one is lymphoma, retinoblastoma, chest tumours, abdominal tumours, and throughout the talk, I'm going to be talking about cancer emergencies, because when looking after such patients and giving them treatment or seeing them for things, you need to understand what the different emergencies are that can occur in oncology, and how to deal with them. So we'll talk about that. That's a lot to get through, and it's really just again an overview of pediatric cancer management. Firstly, if you step back a bit and say, we see lots of children with complicated symptoms, and most of them, of course, don't have cancer, but we need to have ways of recognizing children who might have cancer. And I think these are what I've listed are all the clinical signs of common cancers in children, and many of them overlap with between types of cancer. In general, most children who have cancer, they don't just have one clinical sign, but they're also lethargic or unwell. And on clinical examination, they generally look very unwell. Not always, if it's early, but usually they look fairly unwell. So pallor, easy bruising, bone pain is a frequent feature of different sorts of cancers, especially leukemias, refusal to walk, frequent infections, a lump somewhere, a lump in the bone or a limb, or a lump in the chest, lump in the jaw, lump on the head, abdominal masses. So particularly in children, there's a couple of tumours that cause abdominal masses, chest masses that appear on chest X-ray, and then proptosis. So each of these clinical features are often explained by other illnesses, whether they are other infections or other conditions. But when we see any of these clinical features, we should always think, could it be cancer? And there's been some good work done on this, I think, in many different countries now, to try to raise the awareness of the common symptoms of childhood cancer, so that children will present earlier and be identified earlier. And this is one of those public health messages from South Africa I thought was very good. These are all the signs that I've mentioned to you, but they're listed in an infographic that has been promoted by the South African Paediatric Cancer Society. So here's the early warning signs: a white spot in the eye, a lump somewhere, unexplained fever or weight loss, fatigue, easy bruising and bleeding, joint pains, and neurological signs, difficulty walking and that sort of thing. I didn't mention that because CNS that relates more to central nervous system tumours, but all of these features could easily be explainable by some other chronic illness, an infection, or CNS TB or HIV. But think to yourself, could it be cancer? And if it was cancer, what sort of cancer could it be? I first of all want to start with the most common malignancy and just explain the basics of different sorts of pediatric cancer. The most common malignancy is acute leukemia. And these children, this boy had acute leukemia, and I get an idea from just looking at it, had him what sort of leukemia he had. But he looks quite unwell. He looks quite unwell. And so children with leukemia present with pallor, easy bruising or bleeding, lethargy, anorexia, bone pain, or reluctance to walk. They often have more than one of these features, and they generally have been sick for several weeks at least. If everybody, when they come on, could mute your microphones, please, that would be good. When on examination, they have pallor and hepatosplenomegaly and skin infiltration. So sometimes you see the leukemics infiltrates in the skin. Often they have gingival hypertrophy, gum hypertrophy. About 5 to 10% of them have central nervous system infection at the time, and some boys have testicular involvement. Usually that's not evident when you are examining them. They may have CNS. The children are generally quite unwell, and you'll only find that out usually on a lumbar puncture. Most of the acute leukemias are acute lymphoblastic leukemia. And I want to try to explain the difference between AML and ALL, acute lymphoblastic leukemia, and acute myeloid leukemia. And I want to try to explain the common sorts of acute lymphoblastic leukemia. So most of the acute lymphoblastic leukemias, which is the most common type, are what we call pre-B acute lymphoblastic leukemia. That is the B cells, which normally make antibodies, the B lymphocytes, which normally make antibodies. The precursors of those B cells have become malignant, a malignant clone of the precursors of the B cells. That's why it's called pre-B ALL. About 10 to 15% of all acute lymphoblastic leukemias are T-cell ALL. They come from the T cells, which have a different function, not so much making antibodies, but a different function in cellular immunity. About 10 to 15% are T-cell ALL, and that's much more common in adolescents. It does occur in school-age children and very, very occasionally in young children, but mostly it's in adolescents. And I'll show some examples of that. There's a spectrum between T-cell ALL and lymphoma, non-Hodgkin's lymphoma. I'll explain that. And then about 15% of acute leukemias are acute myeloid leukemias. I'll explain that in a minute. And about 5% are chronic myeloid leukemias. And that's very uncommon, but if you see a myeloid leukemia, most likely it's acute myeloid leukemia, and sometimes it's chronic myeloid leukemia, which of course is much more common in elderly people. It's a different form of CML that occurs in children. This is what I wanted to show, one blood film of acute leukemia, and this is a blood film that you might or might not recognize. This is acute lymphoblastic leukemia, and the reason being, you can see the red blood cells. They're red blood cells with the sort of white target in the middle, the nucleus in the middle. These are lymphocytes, and you can see the very large nucleus of the lymphocyte, and it makes up almost all the white blood cell, almost all the lymphocyte. So that's typical of acute lymphoblastic leukemia. I'll show you acute myeloid leukemia in a moment, and they look quite different under the microscope. So I think it's possible for you to know the difference between acute lymphoblastic leukemia or acute lymphoid leukemia and acute myeloid leukemia. It's possible for us to know that when a child has acute lymphoblastic leukemia or any form of acute leukemia, we need to have some estimation of prognosis. And these days, the prognosis starts off as it's generally very good. And then there are some prognostic features that make it more likely that the cancer will be more resistant to chemotherapy, or the prognosis won't be quite as good. And a couple of those are when the child presents, the height of the white cell count. So if the white cell count is the malignant white cell count is more than 100,000, but it could be more than 200,000 or 300,000 or 500,000. The higher the white cell count, generally speaking, the worse the prognosis, and the more likely the child will get complications when you start treatment. The other prognostic feature that's easy to detect when a child presents is their age. And generally speaking, infants and adolescents don't have as good a prognosis as children aged in between. And that's partly because in infants, often they present late and they have more aggressive forms of leukemia, and they are more prone to toxicity with treatment. And in adolescence, they are more likely to have T-cell acute lymphoblastic leukemia, and that has a not such a good a prognosis. But still, with a child who's got T-cell ALL, T-cell acute lymphoblastic leukemia in an adolescent, you would expect that with chemotherapy, their survival rate might be about 80%, which is pretty good, 70 to 80%, as opposed to children who've got good prognostic features, in which case their outcome is about 80 to 90%. So what's happened in the last 40 years with leukemia is that the outcomes have got better and better with better treatment, simpler treatment, less toxicity, and fewer complications. So they're the prognostic features that we used to use, and now there's some different prognostic features that are based on other things that we can't always measure, such as chromosomal translocations. You probably have heard about the Philadelphia chromosome. If the Philadelphia chromosome is present in acute lymphoblastic leukemia, then the child is more likely to be resistant to chemotherapy. If the child is resistant to steroids at the start of their treatment, if their white cell count doesn't fall, then it's likely that they're more resistant to therapy. If the child's got coexistent central nervous system or testicular disease, then it makes it harder to get chemotherapy to work. And the most important prognostic feature used these days is a bone marrow aspirate at 1 month after treatment. And usually, if you do a bone marrow aspirate after 1 month of treatment, then the bone marrow will have very, very extremely minimal, what we call residual disease. They'll have, their bone marrow will have no or very, very few blast cells in the bone marrow. And so these days, to assess the prognosis of a child, usually it's based on what we call the MRD at 1 month after induction therapy. And if the bone marrow still contains 10 to 20% of cells, then you know they've been resistant to the chemotherapy. But if it contains 1% or less or 2%, then they've had a good response to chemotherapy. The phases of induction of the phases of treatment of acute leukemia, I won't go through these in much detail because, again, this is something an oncologist can tell you, but there is 5 different phases, and they spread over 2 years. And there's induction therapy with vincristine. You need to know the drugs that are commonly used in acute lymphoblastic leukemia: vincristine, daunorubicin, prednisolone, and asparaginase. They're all very important drugs. They all have different side effect profiles. They work in combination, and but they're given in an intensive way for 1 month, usually each week. Each week, the child will get vincristine, daunorubicin, and continuous prednisolone, and weekly asparaginase. That's generally the induction therapy. And then there's what we call a consolidation phase, where the child continues to get vincristine and methotrexate, prednisolone, and then 6-mercaptopurine. And they can be given, apart from vincristine and methotrexate, the prednisolone and 6-mercaptopurine can be given orally. So most of the patients are at home by the time they're in their consolidation phase. Even some children get to go home during their induction therapy, and they come back just for day therapy to get their vincristine and daunorubicin and their injections of asparaginase. Next comes the central nervous system treatment, and whether a child's got a CNS site of their leukemia or not, they get intrathecal methotrexate. If they've got CNS leukemia, that is the leukemic cells have infiltrated the central nervous system, then of course they need a more prolonged course of intrathecal methotrexate. But whether they've got it or not, it's useful. It's important to give intrathecal methotrexate to reduce the risk that the central nervous system will become what we call a sanctuary site for chemotherapy, for leukemic cells, because chemotherapy given systemically, given intravenously or given orally, doesn't cross the blood-brain barrier sufficiently to treat CNS leukemia. After that, the child goes through what's called a reinduction phase, which is re-intensification using the same agents as they got in the first phase of induction. So that's another critical point in their management, where they're getting about a month of intensive chemotherapy, and then they go on to maintenance therapy, which is usually 6-mercaptopurine and asparaginase. So that phase of reinduction therapy, which happens around about 6 months after the diagnosis, is an intense period of time. Again, not all children are hospitalized for their re-intensification, but some are. The good thing about ALL is that about 95% of children go into remission after induction. That is, when you do a bone marrow at 1 month, they've got minimal residual disease, maybe 1% or less leukemic blasts in their bone marrow. And that 80% have a successful cure with chemotherapy. That is 5-year survival rate, around about 80% with the full chemotherapy. And that's a bit lower, as I said, if a child's got T-cell ALL, and a bit lower if they're infants, but it can still be quite good outcomes for such children. I wanted to talk about AML now. So we talked mostly about acute lymphoblastic leukemia, but to understand AML, you need to understand the differentiation, the maturation of granulocytes. So we've talked about lymphocytes, and the other mature white cell in the blood are granulocytes. So lymphocytes and granulocytes, or neutrophils. And if you understand the differentiation, then you'll understand the different types of acute myeloid leukemia. So we start with stem cells, they become promyelocytes, then metamyelocytes, and then myelocytes, and then band forms. You'll be used to band forms because we look for band forms in the peripheral blood, and then they become neutrophils. This is very useful to know, I think, not just for the identification of leukemia and the differentiation of lymphoid leukemia from myeloid leukemia, but also in our management of children with sepsis, because often you see children who've got a lot of band forms or myelocytes or metamyelocytes in their blood film when they've got sepsis, because their bone marrow is producing so much new cells. It's working overtime to produce new cells and put them into the peripheral blood to fight the infection. If you've got acute myeloid leukemia, then one of these cell lines has become malignant, and so you might have acute promyelocytic leukemia, where you have promyeloblasts in the peripheral blood, or myelocytic leukemia, acute myelocytic or myelomonocytic leukemia. So where you've got different forms of one type of immature neutrophil will have become malignant. So AML is, as I said, a cancer of the myeloid white blood cells, and this is a blood film of a child who's got acute myeloid leukemia. The way to differentiate it from acute lymphoid leukemia is that the nucleus looks different. It's a bilobe nucleus. You can see sometimes it's a multi-lobe nucleus, but always it's at least a bilobe nucleus. See how it's not just one big nucleus that looks like two nuclei together, a bilobe nucleus. And that indicates that they're white cells of the myeloid origin. Remember that these are premature or immature neutrophils. And acute myeloid leukemia makes up about 20% of childhood leukemias. Remember, 80% is ALL, about 20% is AML. And as I said, sometimes you can see clinically what type of AML the child's got. So, for example, if I see a child with AML who's got severe coagulopathy or disseminated intravascular coagulation, then often they have acute promyelocytic leukemia, because typically they have a coagulopathy when they present. Or if I see a child who's got like intense skin infiltration with leukemic cells or gum hypertrophy, then they're most likely to have acute myelomonocytic leukemia. You don't need to know this. I think what's important is to be able to differentiate between acute lymphoid leukemia and acute myeloid leukemia, and to understand the difference between ALL, which is of pre-B origin, and ALL, which is of T-cell origin, and then acute myeloid leukemias. The central nervous system is more commonly involved in acute myeloid leukemia, so not 5 to 10%, but about 5 to 15% of all children will have CNS leukemia. And the survival rates in AML are not nearly as good as with ALL, around about 50 to 75%, depending on the treatment that's given and the response to their treatment. So the survival rates are quite less, but still that's not a bad survival rate for a condition that is universally fatal without chemotherapy. I mentioned before that some lymphomas can be extensions of T-cell ALL. There's a spectrum between T-cell ALL and lymphomas, or they can be a lymphomatous. Lymphoma are like mass disease, where you don't have leukemic cells in the peripheral blood. They're different, but they're similar origins. So most lymphomas that we see are B-cell in origin. So about 70% are B-cell and about 30% are T-cell origin. And the T-cell lymphoma, as I said, is part of this spectrum of T-cell ALL to T-cell lymphoma. And the common feature is that they arise from T cells, and the T cells are produced by the thymus. So often in children who have T-cell ALL, they'll have a major thymic mass. They'll have a widened mediastinum with a major thymic mass. Most of these children, as I said at the start, are between in adolescence, compared with ALL, where usually children at 2 to 5 years of age, the most common age, and AML, which occurs in all ages. Children with T-cell ALL present with a mediastinal mass. Sometimes they present with what we call SVC syndrome, or the obstruction to the superior vena cava, or obstruction to the trachea, typically at the carina, or bronchial obstruction. And so they may present, many children I've seen who presented with a month or 6 weeks of wheeze or stridor, and people have thought they had asthma or they have croup or something like that. They often present with more than just that. They may present, because of their mediastinal mass, it produces an effusion, so they may have a pleural effusion or sometimes a pericardial effusion. So if you ever see a child who's got a mediastinal mass, think to yourself, could there also be a pleural effusion? Could there also be a pericardial effusion? Because managing that is often very important. Children who have T-cell ALL or Burkitt's lymphoma, B-cell ALL, have a lot of mass disease. They have a thymic mass. They may have a big liver and a big spleen. And the larger the amount of mass disease, the higher the risk of tumor lysis syndrome. This also applies to children who've got ALL or AML that have white cell counts that are above 100,000. When you start treating them, they're at very high risk of getting tumor lysis syndrome. You hope they get tumor lysis. That's what the chemotherapy does. But tumor lysis syndrome is something else that I'll talk about shortly. This is a child who's got T-cell lymphoma. And you can see from the X-ray, he's got a mediastinal mass, and he presented with 3 weeks of wheeze and was treated with bronchodilators, with beta-2 agonists, salbutamol, Ventolin, and steroids. And but you can see that he's got a very large mediastinal mass, which is in that. I want you to just see on the lateral X-ray It's in the anterior mediastinum. Okay. If you see a child who's got a mediastinal mass, always take a lateral X-ray, because you can then assess whether or not it's an anterior mediastinal mass, or a middle mediastinal mass, or a posterior mediastinal mass. Because the different sorts of tumours exist in different parts of the mediastinum. For example, lymphomas always arise from the T-cell lymphomas always arise from the thymus, so therefore in the anterior mediastinum, whereas a neuroblastoma arises from the sympathetic chain, and that runs along the back adjacent to the spine, so they always arise from the posterior mediastinum. And then the tumours within the middle mediastinum, where you've got the pericardium, where you've got the esophagus, where often different sorts of tumours, like a bronchial tumour, an adenocarcinoma, or a pericardial tumour, or a teratoma. So knowing where the tumour is within the mediastinum helps you understand what type of tumour it is. And so taking a lateral can be very useful. If you've got a CT scan, then you can tell, of course, on the CT scan. I'll mention CT scans and mediastinal masses in a moment. It's not that simple to do a CT scan in a child with a mediastinal mass. These patients, as I said, with mediastinal masses and with very high white cell counts, are at highest risk of tumor lysis syndrome. And that's when the white cells are killed by the chemotherapy, they lyse, and they release all the cellular chemicals. So we've got lots of phosphate inside cells. When you think about it, adenosine triphosphate, lots of nucleic acids which have phosphate in them, that they release phosphate and nucleic acids that break down, and there's lots of potassium in cells. So hyperkalemia, hyperphosphatemia, high uric acid because of the breakdown of DNA that occurs within cells. They characterize tumor lysis syndrome. There's a release of phosphate, of potassium, uric acid from DNA breakdown, and that leads to hyperkalemia and often a severe metabolic acidosis. And then the phosphate that's released from inside cells combines with calcium in the blood and often leads to severe hypokalemia, a very low calcium level. And this is, in some ways, there's several major risks of tumor lysis syndrome. One is severe hypocalcemia, and the other one is kidney failure, because acute kidney injury, because of the uric acid released, can cause tubular obstruction in the kidneys and can lead to kidney failure. So for both those reasons, you can get an acute kidney injury. So our strategy is to try to avoid tumor lysis syndrome if we can, and that involves preventative management. This is a boy who had tumor lysis syndrome, and you can see he's got tetany. He's got tetanic spasms of his hands because his calcium level was so low, 0.4 it was at the time. And that's because he had phosphate released from his the breakdown of his cells. The phosphate combines with calcium, the calcium level goes low, he then gets tetanic spasms of the limbs. The treatment for it is, or the prevention is, to give allopurinol, which can protect the kidneys. It's a xanthine oxidase inhibitor. It protects the kidneys from the breakdown products of DNA, the uric acid, and to give hyperhydration, to give more fluid than we normally give, at least 1.5 times normal, sometimes up to 2 times normal. Now, the problem with this is that by giving hyperhydration, many children get fluid overloaded. And if they get fluid overloaded, then they will often have a worse outcome. They'll get wet lungs, their kidneys will get worse. So when we're giving hyperhydration, it's very important. You don't just give fluid in. You must make sure the fluid comes out. And the fluid in can be 1.5 times normal of their maintenance fluid, but you have to make sure the fluid comes out. And that can be done in several ways. one with diuretic therapy, or by adding a bit of mannitol or furosemide to the fluid. But make sure if you are giving peri-chemotherapy hyperhydration, that you make sure that as much fluid comes out as goes in. Is very important, because I see more children get into trouble because they get hyperhydration and nobody thinks about the need for a diuresis, as I do children who get problems with tumor lysis syndrome. We can alkalinize the urine too. So using the fluid can contain some sodium bicarbonate. If you alkalinize the urine to a pH of 7 or 8, then you reduce the risk of uric acid causing tubular obstruction. And if at all possible, we should avoid intravenous calcium, giving intravenous calcium replacement. And the reason for that is because if you give calcium, then all you do is you give calcium, and that will combine with phosphate, and therefore you'll get more deposition of calcium. Phosphate is just chalk. Imagine getting deposition of chalk in your arteries or in your kidneys. And so for this child that I've shown you with a calcium of 0.4 and tetany, of course, he needed to have calcium. But unless you've got very severe hypocalcemia, it's better not to give intravenous calcium until you've got the tumor lysis under control. If you've got tetany, then give calcium. But if not, then probably try to avoid it until your phosphate level is normal. I wanted to talk about Burkitt's lymphoma because, as I said, it causes about 30% of all lymphomas. Most of them are T-cell lymphomas, but Burkitt lymphoma is actually quite common, and it's especially common in Papua New Guinea, and we'll talk about why. It is the fastest growing human cancer. And so when we see children who look like this is a boy who's got Burkitt lymphoma, you might imagine they've had a very late presentation. Well, it is late, but it can grow very rapidly. And that's because the cells are turning over very rapidly. So you've got no time to lose with the management of Burkitt lymphoma. They present in a similar way to other lymphomas and many other chronic illnesses, with fever and weight loss, night sweats, often painless lymphadenopathy. So generally speaking, this won't be painful apart from the stretch on the skin. It is the reason why it's more common in Papua New Guinea and in Africa. There's two types of Burkitt lymphoma, and one is what we call the jaw type, or the African type. This is the boy that I've illustrated here. It has the African type, Papua New Guinea type, if you like, jaw mostly involved. The other type is what's called a sporadic type, or an American type. It's sporadic, as in it's not related to anything in particular, not related to genetic influences or environmental influences, and it can cause gastrointestinal tract or lymph node involvement, a bit like T-cell ALL, but it doesn't arise from the thymus. But particularly gastrointestinal Burkitt lymphoma is usually the sporadic type, whereas the endemic type is mostly involves the jaw, and that relates. It's more endemic in countries and locations where malaria is more frequent, and it's the combination of malaria and Epstein-Barr virus that leads to malaria causing a reduction in immunity to Epstein-Barr virus, the glandular fever virus, and Epstein-Barr virus leading to a lymphoproliferation that can lead to Burkitt lymphoma. So that's the mechanism by which children in tropical countries that are malaria endemic are more at risk of Epstein-Barr virus. It's partly genetic in origin too, because there is a change in the genetic epigenetics to lead to mean that Epstein-Barr virus is more likely to lead to lymphomatous proliferation. It can also be caused by HHV6 and by HIV. That children who've got HIV or HHV8 are more likely to have lymphomatous proliferation than other children, especially if they're in a malarious endemic area. There are some genetic risk factors as well. mostly these children present with the mass. They have pancytopenia because it involves the bone marrow also. They have a very raised uric acid level because the cells are turning over very fast. They're dividing very fast. And they have a high LDH. They're the features that you should look for. As I said, it occurs more commonly in Papua New Guinea. In fact, Burkitt, the scientist who first described Burkitt, his lymphoma, Burkitt B-cell lymphoma, did come to Papua New Guinea and also identified Burkitt lymphoma or B-cell lymphoma in Papua New Guinea, but also he worked for many years in Africa. In PNG, it makes up about 16% of childhood malignancies. That may be dropping a bit as malaria and other infectious diseases fall, and other cancers like acute lymphoblastic leukemia, pre-B, ALL, and other cancers increase. But the studies suggest it's about 16% of childhood malignancies. Most children are just school age, sort of 5 or 6 years of age. Much more common in males than females, much more commonly causing jaw or other facial structures malignancy. As I said, the immune pathogenesis of why is Burkitt so much more common in PNG? Well, the thought is that there's chronic immune suppression by malaria that results in lymph nodes developing Burkitt's lymphoma in response to EBV infection or HHV8 or even HIV. So that's the origin. I think it's an interesting observation that's been made with Burkitt lymphoma. This is I showed you before a child who had endemic Burkitt, the jaw version. This is a CT scan of a child who's got an abdominal Burkitt lymphoma, and you can see how massive the tumor is. This is the tumor here, making up all of this area. This is his bowel, and it's Burkitt lymphoma can be relatively small, or it can be very large intra-abdominal mass, often involving the bowel. I showed this because this is the histopathology of a child who's got Burkitt's lymphoma. And you can see the neoplastic proliferation of B cells. These are B lymphocytes within the tumor, and interspersed reactive histiocytes. Remember, histiocytes are forms of macrophages, and you can see reactive histiocytes. This is often called a starry sky histology. This is just for the people who like histopathology or like painting. This is one of the most beautiful paintings in the world. This is Van Gogh's Starry, Starry Night, and that's what this histopathological appearance is named after, the histiocytes surrounded by the B cell proliferation. The treatment for Burkitt's lymphoma, as I said, it's a very fast-growing tumor, and it needs to be treated with, the treatment is what's called CHOP, cyclophosphamide, doxorubicin, vincristine, and prednisolone. It also stands for the Children's Hospital of Philadelphia, which is where the first Burkitt treatment was given. Children's Hospital of Philadelphia in the US, of course. But it is a useful acronym for the treatment that is used for Burkitt's lymphoma. You need to, if you're starting treatment with Burkitt's lymphoma, you should start as early as you can because it's rapidly growing, and you know that in those children, then tumor lysis will certainly occur. I wanted to cover so that's leukemias and lymphomas. I wanted to move now to some other solid tumors, retinoblastoma. So this is a child, as you can see, who's got a retinoblastoma. It could be other things like a rhabdoid tumor of the extraocular muscles, but it's a retinoblastoma. And it's sad but true that most children with retinoblastoma present like this. They have advanced disease at the time they present. But if you identify children early, they can have a good outcome from retinoblastoma, and they can be identified early by identifying basic signs. So many such children have a squint, And so, of course, a squint can be a congenital problem, but if a squint occurs in a child who didn't have one before, then think about, could it be a retinoblastoma, or could it be a CNS tumor? I mean, you see squints in children who've got gliomas and other forms of central nervous system tumor. That a new onset of a squint should always be investigated. It often means a tumor or malignancy of some sort. Most children are less than 3 years. Almost all children with retinoblastoma are less than 5 years. The genetics of retinoblastoma is also complex, a bit like Burkitt lymphoma. They're not associated with any infections, but they are associated with what's called some germline mutations, where there's mutations in the egg and the sperm or the egg in the retinoblastoma gene. There's a retinoblastoma gene, and a mutation in that can lead to a bilateral retinoblastoma. So unfortunately, some children get bilateral disease. About 1/3 of all children will have bilateral disease, and sometimes they'll have disease also in the brain. So identifying children with retinoblastoma can be done early. This is a baby who had retinoblastoma who was identified very early. You can see the leukaemia, which is just a white reflex. Usually, if you shine a light on the retina, of course, it's red. This is not a red reflex, it's a white reflex. And this was a baby who had retinoblastoma and was able to be managed very early without needing enucleation. The treatment for it, there's many different treatments these days. Systemic chemotherapy, other forms of treatment, cryoablation is sometimes used, laser photoablation, and sometimes they put even radioactive plaques within the eye. Sometimes the chemotherapy is given intraarterial, like through the ophthalmic artery. That seems to have the best outcome, but it requires quite complex interventional radiology to do that. And then sometimes children who failed systemic chemotherapy, which is the mainstay of treatment, need to have enucleation. Now, if the child's had already got spread to bone or the central nervous system, then the treatment is almost always fails. But if they've got early disease, then sometimes enucleation can be life-saving for these children. I won't get into the complexities of managing retinoblastoma, but just to make sure you can identify it as a common tumor. I was going to go on to talk about chest tumors, and I briefly mentioned some of those in the past, just before. So I talked about T-cell lymphomas arising from the thymus, and some other tumors can arise from the thymus, a thymoma. They typically occur in adolescents and especially female adolescents. Some tumors arise from the sympathetic ganglion, which runs down the spine, adjacent to the spine, like neuroblastomas or ganglioneuromas. And then remember they're in the posterior mediastinum. And then there are some sarcomas that arise from muscle or bone, ribs, and they can cause a chest mass, a unilateral or sometimes midline chest mass. And then there are some teratomas, usually unilateral, arising from germ cells within the thoracic cavity. Let's go back a step and say some of these tumors, chest tumors, can be identified, have to be differentiated from other causes of a whiteout of the chest. And usually when we see a whiteout of the chest, well, remember, a whiteout of the chest can be only one of four things. It can only be fluid or consolidation or collapse or a mass. They're the only four things it can be. And if it was fluid, then you think, well, it could be an empyema, or it could be an effusion. It could be blood, like a hemothorax. It could be lymph, like a chylothorax. If it's not fluid, Could it be consolidation? If it's consolidation, we should see air bronchograms, or it could be lung collapse. That can give you a whiteout of the chest, but usually then the mediastinum will be shifted over to the other side, to the affected side. Or it could be a mass, in which case a mass or a tumor, in which case the mediastinum is shifted to the opposite side, and there may be some other features of a chest mass. So if you see a whiteout of the chest, then ask yourself, are there any of those other features that would indicate what the whiteout is due to? Is it fluid? Is it consolidation? Is it collapse? Or could it be a mass? Sometimes it can be a mass and fluid, and that makes it complicated. So this child had a chest tumor, and I think you can see on the CT scan the chest tumor, but this child also has an effusion. You can see the fluid surrounding the lung is black, the mass is grey, the effusion is darker grey. So this is a child who had a chest tumor and, of course, a malignant effusion, peritumor effusion. So sometimes it can be a little complicated, but that's what it can look like. This is another child also, you'd say this is a big empyema or a big effusion, but actually had a chest mass with an effusion. This is the chest mass. Here's the heart, which is squashed. You can see the contrast in the ventricles and the atrium. And then this is the chest mass, and then you can see the surrounding pleural effusion. So just because it's an effusion, which it is, doesn't mean there couldn't be a mass underneath it. And the only way to work that out is to drain the effusion and then re-X-ray the child and see what's there. You can see also here the mediastinal shift, how the mediastinum is shifted across, the trachea is deviated to the right-hand side because the mass is on the left-hand side. This is another chest mass, and this is an interesting X-ray that tells you it also tells you what sort of mass it is. So remember, the mass is if it could be in the anterior mediastinum or the middle mediastinum or both, and it's also what we'd say is heterogeneous, isn't it? It's not the same density all through like the previous X-rays I showed you, but there is different levels of density. And this is a classic case of a child who's got a teratoma, where you've got lots of different sorts of tissue inside it, be it calcified bone tissue or other fibrous tissue or muscle tissue within the teratoma, primitive tissue within the teratoma, and that's why you see these areas of calcification within it. So that's what a teratoma looks like, a chest wall teratoma. Teratomas can be involving the chest, or sometimes a relatively common teratoma actually in Papua New Guinea is a sacrococcygeal teratoma. This is a sacrococcygeal teratoma, which is often a congenital malignancy. This baby was just born with the sacrococcygeal teratoma, and it arises. It's a germ cell tumor that arises from the testes or the ovary. It's extragonadal, usually extends further. There are some tumor markers. The beta HCG is high and alpha fetoprotein is high, just like in other germ cell tumors. Mostly these tumors can be completely excised. They're benign. They don't spread to other organs. And they can, if you leave them, undergo malignant transformation. But usually if you excise them in the first month of life, which this baby had a complete excision, then they can be shelled out quite easily. The most difficult part of the operation, in a way, is actually the sort of surgical reconstruction of the perineum afterwards, which the surgeons in Goroka were skilled enough to do, which was a good thing. This baby did very well with surgical resection of this non-malignant teratoma, congenital teratoma. The baby had to be born by cesarean section. because to avoid obstructed labour, of course. Sometimes they can be bigger than that. Sometimes they only present post-delivery in the neonatal period. But if you see a lump on the back or a lump in the perineal region, then think about it, a germ cell tumour, a sacrococcygeal teratoma. Finally, I wanted to talk about abdominal tumours, and I've mentioned some of these before, but there are 5 main abdominal tumours, and the ones the most important to know about are Wilms tumours and neuroblastomas. I've also already talked a bit about Burkitt tumours, which are the sporadic type of Burkitt's, not so associated with, not so common in PNG, not so associated with malaria or EBV. They arise spontaneously, the Burkitt's, and they're teratomas, which are germ cell tumours. They may arise from the ovaries or the testis, other germ cell lines. But let's talk about, and hepatomas are also relatively more common in PNG, and that may relate to hepatitis B carriage, which is more common in some populations, and that the hepatitis B carriage is a precursor often of hepatomas. We'll talk about abdominal tumours now. Wilms tumours are usually, they present in young children around about the age of 2. They present with a painless abdominal mass. Often the child is relatively well. Occasionally the child will be sick because about 20% of them bleed or rupture, leading to pain. But mostly it's just a progressive mass, and usually the mother notices the tumour when they bath the baby, or they've dried the baby with a towel, or when they change the baby's nappy, they might see a lump in the abdomen. And so if you get that story of the mother noticing a lump in the abdomen, then it's quite likely it's going to be a Wilms tumour. They may present with hematuria in about 1/4 of all cases, and sometimes they present with hypertension, or the child has hypertension when they present. There are some congenital abnormalities that are associated with, excuse me for a moment. Yeah, just hold on a sec. Yeah. Sorry. So there are some congenital abnormalities, chromosomal abnormalities, that are more associated with Wilms tumour, and I won't go into them, but there's one condition called Beckwith-Wiedemann syndrome. Sometimes children have congenital, like genitourinary abnormalities like hypospadias or hemihypertrophy, which is an enlargement of one side of their body. These are just random chromosomal abnormalities that are associated more with Wilms tumour. Most children don't have these changes, of course. Most Wilms tumours are unilateral, and about 7% are bilateral, and some are multifocal. That is, they arise from not only the kidneys but also other parts. They metastasize mostly to the liver and the lung, but mostly when children present early, they haven't metastasized. And sometimes they extend to the renal vein, so the tumour grows from the kidney into the renal vein, which... Oh, sorry. Okay. If a tumour is metastasized to the liver or the lung, then the prognosis is not as good, but mostly the prognosis is actually very good with chemotherapy. This is the ultrasound of a kidney, and within that is a typical Wilms tumour. It's a bit hard to see. You need to get good at looking at standard ultrasounds of a kidney, but this doesn't look anything like a normal kidney. It looks like there's a big mass within the kidney. Again, you need to look at a few sounds of the kidneys. The question is it cystic or solid? Is there intravena cava extension? Has it gone up the renal vein into the IVC? And is there a tumour in the opposite kidney And is there liver or abdominal evidence of metastases? These are all questions for the ultrasound. When you're doing an ultrasound and you find a Wilms tumor, then you need to ask these questions. The treatment for Wilms tumor is surgery and chemotherapy. Treatment takes about 15 to 25 weeks. Mostly children get weekly chemotherapy for about 10 weeks, and then they have an excision of the tumor. The chemotherapy is doxorubicin, actinomycin, and vincristine. And the reason to give chemotherapy before doing surgery is that when you excise the tumor, you don't want to spill any into the peritoneal cavity, because otherwise you might get spontaneous metastases, or metastases that are caused by the surgery in the peritoneal cavity. So that's why chemotherapy is given before trying to remove the whole tumor. Sometimes the whole kidney has to be removed often, but sometimes there can be salvage excision of the tumor and the rest of the kidney is left intact. And I've seen 2 children in the last few months that have had bilateral Wilms tumors, and they've both had kidney sparing surgery. That is, the surgeons have been able to cut out the tumors, even though they were very large tumors, and the kidney's still been able to operate good enough that the child didn't have renal failure. So even in what we call stage 5 Wilms tumor, where there's 2 kidneys involved, it is possible to have surgery after 10 weeks of chemotherapy. The prognosis of a good prognosis Wilms tumor that doesn't have metastases, that doesn't have extension into the renal vein and up the IVC, is very good. 90% 5-year survival if the tumor's in the early stages. There are some abnormal prognostic, poor prognostic features, like there's a Wilms tumor called an anaplastic Wilms tumor, which is more undifferentiated cells, and those children have a worse prognosis, but that can only be detected on histopathology. The last tumor I wanted to talk about, I think it's the last one, is a neuroblastoma. And a neuroblastoma also arises in the abdomen. And this is a child who's got a neuroblastoma. Remember, it arises from the sympathetic ganglion, which run adjacent to the spine. So it's arising in the posterior part of the abdomen, or in the posterior mediastinum. I'll just go through the different parts of the on the CT scan. You can see the gas in the stomach. This is a normal spleen. This is the spine being hyperdense on the CT scan. This is the right kidney, which is normal, and this is the tumor, the large tumor that's arising from it could be a Wilms tumor, but this was a neuroblastoma. The fact that it's very heterogeneous again suggests it's a neuroblastoma. As I said, it's a tumor of the sympathetic nervous system. It affects the adrenal glands in about 40%, so it'll sit at the top of the kidney, or sometimes it affects the sympathetic chain, the sympathetic ganglion in the abdomen, posterior, or the chest, posterior mediastinum, sometimes in the cervical chain, so it'll lead to a mass in the neck, and sometimes in the pelvis. Mostly these children present often with more advanced disease, so they might have the children have a abdominal mass, but they might have other things like severe anemia, or what's called opsomyoclonus, which is myoclonic movements of their eyes, like nystagmoid movements of their eyes. The point is, they're often less well, they're often more malnourished, they're often anemic, and they have evidence of metastases often, not always, but often at the same time as they present in their lymph nodes, or their bone, or their CNS, or in their liver or lungs or their brain. Now, not all children with neuroblastoma have such metastases, but many, many more do than if they've got a Wilms tumor. Compared with Wilms tumor, as I said, children are often more unwell, whereas Wilms tumor, the typical thing is it's just an abdominal mass, maybe with hematuria. There are some unusual features of neuroblastoma, and one is that in young infants who've got disseminated disease, they can have a very good outcome, even with stage 4 disease. They have what's called stage 4S, which is disseminated disease, and they have a good outcome with treatment with chemotherapy and surgery, as opposed to if you're a child around about 2 years of age or older with stage 4 disease, then they have a very high mortality, even despite intensive multimodal chemotherapy. As you probably know, neuroblastomas secrete catecholamines, so you can measure catecholamines in the urine, and sometimes they have hypertension because they have a surges of catecholamines. Hypertension, of course, can occur in Wilms tumour as well, but it can also be a feature of neuroblastoma. The chemotherapy I won't go into too much, but it's more intensive chemotherapy than is given for Wilms tumour. The prognosis isn't as good using different chemotherapies, so cyclophosphamide, carboplatinum, or cisplatin, etoposide, and doxorubicin. It's very intensive chemotherapy. The children tend to get quite sick with it, but for some parents, they will want to at least have a try at treatment of their tumour. So I wanted to go back now to what I said earlier, that one important thing is to be able to recognize pediatric cancer, to know the symptoms and signs that tell us that a child might have malignancy. They might have something else too, but this is things we need to know. So pallor, easy bruising, bone pain or refusal to walk, frequent infections, a lump anywhere in the chest, in the abdomen, abdominal mass, a chest mass, or proptosis or a squint, and leukocoria, that white reflex in the eye. So if you remember those things, that will be good. So I've just gone today over, I really wanted to go just over the basics of pediatric oncology. I know that was a lot to pack into just 1 hour, but you'll be able to read up on the more details of these cancers. But this is these are the basics of pediatric cancer, and I thought it was worth going through that once, and then you can read up further. So I'm happy to answer any questions that you might have on any of these tumours. But you've got also Dr. Gwenda Anger and Dr. Benjamin Dow to ask about more details of chemotherapeutic regimes, and our colleagues in Indonesia have your own pediatric oncologists. I don't pretend to be that. I'm just a generalist who looks after a lot of children with cancer. So I'm going to finish there, and happy to answer any questions that you might have.